All right, let's talk about one of the heavy hitters in orthopedic trauma, the tibial pilon fracture. These are the injuries that are not only a massive challenge in the operating room, but they're also a hot topic and a pretty tough one in any consultant-level exam. So let's get right into it.
First things first, get the idea of a simple angle fracture right out of your head. This is a whole different beast. We're talking about a catastrophic joint injury. The mechanism is usually a big, high-energy axial load, a fall from a ladder, a major car crash, where the talus basically acts like a pestle and just smashes up into the tibia, the mortar, bursting it from the inside out. This image here, it captures that destructive force perfectly.
So here's how we're going to break it down, with a real focus on what you need to know for your exams. We'll start with the basics, what is it, then get into classification, how to assess it, the all-important management protocol, the tough-to-swallow complications, and we'll finish up with those Viva pearls that'll really make you shine.
Okay, section 1. Let's lay the foundation. What exactly is a pilon fracture?
The definition here is everything, and you've got to be precise. It's an intra-articular fracture of the distal tibia. The two phrases that are absolutely critical are intra-articular and weight-bearing surface. This isn't just a broken bone in the leg. It's the shattering of the tibial plafon, the actual joint surface. And that, right there, is why the long-term prognosis can be so grim.
Now you might think, well, they're pretty rare, right? And you'd be correct. They make up less than 1% of all lower extremity fractures, but they punch way above their weight. Their severity and the sheer difficulty in treating them make them a huge deal in the world of trauma surgery.
And hey, if you want that extra point in your Viva, dropping a little history never hurts. The name pilon actually comes from the French radiologist Etienne Destoux. Way back in 1911, he's the one who first described that pestle and mortar mechanism. It's a nice touch that shows you got a deeper appreciation for the topic.
Okay, let's move on to classification. And look, this isn't just about memorizing some tables for an exam. Understanding these systems is absolutely fundamental to how you're going to plan your surgery. So, picture it. You're in the hot seat. The examiner slides a complex-looking X-ray across the table and asks you that exact question. What's your thought process? What classifications jump to mind?
Well, you'd probably start with the classic, the Rudy-Alguer classification. It's simple, it's a great starting point, it gives you a quick idea of the severity, from a simple non-displaced split all the way to a completely comminuted displaced mess. But, and this is a big but, it's limited. For the really complex, multi-part fractures we see all the time, it just doesn't give you enough detail to actually plan an operation.
And that's because modern management absolutely relies on CT. This axial view right here, this is where the real work begins. You have to identify the key players, the anterolateral chap-up fragment, the posterolateral Volkmann fragment, and that critical central die-punch piece. Finding these fragments is what tells you everything. Where to make your incision, what plates to use, the whole shebang.
Okay, let's switch gears. We're in the emergency department now. The patient has just rolled in. What are the absolute critical first steps you need to take?
First up, ATLS, always. Remember, about 6% of these patients are polytrauma cases, so you have to look for other life-threatening injuries. Next, a detailed neurovascular exam is non-negotiable, and you have to do it both before and after you do an early closed reduction. That reduction is so important to take the pressure off the skin. And of course, if it's an open fracture, it's an immediate trip for a washout, debridement, and start the IV antibiotics.
And this brings us to one of the most important buzzwords you'll ever hear for this injury: span, scan, and plan. Think about it. Getting a CT of a completely displaced, shortened fracture isn't that helpful for planning. The key is to first span the joint with an external fixator to get length and alignment back. Only then, once things are stabilized, do you scan with a CT. That's the scan that lets you actually plan your definitive surgery.
And that leads us perfectly into the modern gold standard of care, the staged management protocol. The entire philosophy, the whole reason this exists, is based on one single overriding principle. You must respect the soft tissues.
Sure, non-operative management is an option, but only for those patients who are medically just not fit for surgery. For pretty much everyone else with a displaced pilon, the consensus is clear. Surgery is the way to go. The real debate isn't if we operate, it's how, and most importantly, when.
So here's the protocol in a nutshell, pioneered by guys like Sirkin and Sanders. Stage 1, you span it. You put on that external fixator to hold everything out to length and give the soft tissues a break. Then, you wait.
You wait for the swelling to go down, you wait for that classic wrinkle sign to appear on the skin. This could be 10, maybe even 14 days. Only then, when the soft tissue envelope is ready, do you go in for stage 2, the definitive ORIF.
And this right here is the goal. On the left, you see the absolute chaos of the pre-op CT. That joint is just blown apart. And on the right, the post-op X-ray. The goal is anatomical reconstruction. You're trying to turn that chaos back into order.
But even if you get a picture-perfect reduction in surgery, the story is far from over. This is where we have to talk about the tough stuff, complications, and long-term outcomes. This is a massive part of any consultant-level discussion, and it's all about managing patient expectations.
And the biggest long-term complication, the elephant in the room, is post-traumatic osteoarthritis. The numbers are just staggering. As you can see here, more than half of these patients will develop significant arthritis within just 5 years. That's a brutal statistic, and it's one you have to be upfront with your patients about from day one.
So what separates a good outcome from a bad one? Well, it really boils down to 4 main things. How bad was the initial injury to begin with? How good of a job did you do reducing the joint surface? Did you restore the overall alignment of the leg? And then, of course, you have all the patient factors like age, smoking, and other health problems.
All right, let's wrap this up and bring it all home. Let's talk Viva pearls and buzzwords, the stuff you need to have locked and loaded to really nail this topic in your exam.
Here are the common traps people fall into. The number 1 mistake, rushing to fix it on day 1. You have to talk about the staged protocol. Forgetting to span before you scan is another big one. And you have to be ready to discuss what to do when the joint is just too shattered to fix. You need to be able to talk about salvage options, like a primary fusion.
And finally, here's your checklist. These are the buzzwords you need to know and use correctly. When you talk about the pestle mechanism, the stage protocol, and respecting the soft tissue envelope, you're signaling a clear, confident, consultant-level understanding of how to manage these incredibly difficult injuries.
So I'll leave you with this final thought. It's a tough question. We put so much time, effort, and metal into getting a perfect anatomical reduction, and yet that arthritis rate stays stubbornly, frustratingly high. It really forces us to confront the central dilemma of the pilon fracture. If the cartilage is destroyed at the moment of impact, what are we really fixing?